All right, everyone. So, what we're doing with today's lecture, my part of it, anyways, is to kind of give you some osteopathic considerations for pathophysiology. So, what that means is, for example, there's the kind of basic pathophysiology of disease, which is a list of signs and symptoms and then a diagnostics, or at least a name or some terminology. So, you've all heard the term ankle sprain, right? And you've all heard the term Osgood Schlatter. Everyone's heard the term, or you will at least by now have heard the term Lisfranc injury or Lisfranc fracture or Lisfranc dislocation. So as much as those things are important in terms of the communication within the medical world, we have to also consider that we look at things in an osteopathic sense differently. And what I mean by that is we're looking at things in terms of the terms and ideas of local, regional, and global, right? And so sometimes there's considerations that are local and are still osteopathic, regional, and then considerations that are global or systemic. And so when I'm talking about something that is more local, we're talking about something that is more typically organized in a transverse sense, right? And later on when we study embryology, we'll find out why. But if you like to understand the basic organization of the body embryologically, right, in terms of actual structural development of the mesenchyme and mesodermal tissue, is longitudinal. So those structures like the aorta and the vena cava, those are the initial developed structures to take fluid, which is at this point not even blood, it's just mesenchymal fluid. It's a future, in the future it will be blood, taking that stuff and having it travel to the periphery and having it return. The next stage of development after that are oblique or spiral shaped structures, right? And the last structures to develop in terms of this organizational process are transverse. So those are the small arteries that come off perpendicular to the longer longitudinal structures. So examples of, say, the regional organization or spiral-shaped structures are things like the scalene muscles, which again comes from the mesoderm, right? The psoas muscle, which comes from the mesoderm, the oblique muscles, right? And the intercostal muscles. Those are all oblique-shaped muscles. So we know that they, because they're oblique, because they have a spiral pattern, we know that they are intermediate in terms of development. Likewise, the transverse muscles, or the transverse structures of the body, they are local in terms of development. That's the last stage of development before a more complex organization that happens at a different stage of development. So why I mention that is because we're always going to be trying to look for regional, right, local, or systemic processes within this term disease. I don't even like the term disease. I think it's better for us to think of disorganization, right? Because ultimately, what we're talking about here is an error in organization or an error in behavior. So, that being said, let's start working through what we've got to work through. And I think the best way to look at that is let's have some fun with this. You might say, well, this is no fun at the moment. I'm like, this is fun for me. So I invite everyone to take this material not as something they learn just for rote memorization purposes to regurgitate later on, but really look at this material like it's a living picture. When someone says Osgood Schlatter, don't think of, oh, changing the periosteum, too much pressure in the blah, 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 this connective tissue and the muscle. Throw that away. Look at things like there's something going on locally, regionally, and systemically. I mean, if someone has a fracture of a metatarsal, say a common one, fifth metatarsal head, right? Okay, so like that's easy to look at as an accident that happened. But the implications of that are systemic. You're not healing a fracture, you're helping to prevent what's happened in the process of the fracture and then compensation afterwards. You're helping to prevent that from becoming permanent adaptive behavior. So an interesting clinical case, and I might as well mention it now because it kind of works with what we're dealing with. I'm now working with one woman. I've seen her over the years. She had a surgery for bunion twice, didn't go well. And now she's got a gait pattern where she tries to avoid putting any pressure on her big toe. So how do you think that's going to work for her? Not too well. Now she's got major problems with her fibula, lateral knee, hip joint, SI joint in her right. Why? Because she's walking in a way that's adaptive for the pain, but it's not very effective in terms of long-term behavior of movement through the whole body. So next time you see someone, just be thinking in your mind right away, local, regional, systemic. All right. Okay. So the living picture is really, that's an important concept for us, right? That comes down from still, right? And the idea of the living picture, it's a complexity concept as well. And the idea is in our minds, when we have a living picture, it's process and behavior. So what does that mean for us? You can layer information. It's inherent to the concept of the living picture, right? There's no such thing as something that exists in one dimension, in one frame of time, right? Things have a history. It's inherent to their existence. They have a scalability. My computer has a certain size, right? Within my computer are parts that are inherently smaller and make up the whole. Within those parts are other parts. And then we can go down and down and down until we get to the level of molecules, right? And if you think about this computer being on the network or being networked with other computers, you can see this can expand. The bigger something is, inherently, there's more working parts that makes it more complex. Scale is important for us to always consider. Another concept, when we're looking at what I'm going to call a pathology, but I'm calling it only a pathology today. Let's call it process. What I want you guys to think about is the time scale for that process. So I just mentioned something about like how there's a time scale and a dimensionality to my computer. Well, think of the same thing for the process you see. So let's use ankle sprain again. Ankle sprain. What tissues are being affected? Well, we know the ligaments are being affected, right? What are the ligaments made up of? Connective tissue, fine. Is there collagen in the ligaments? Maybe. Okay, absolutely. There better be collagen in those ligaments or you don't have a ligament. What's the time scale of change for collagen? Right? If I have collagen that's being laid down again, how long is that going to take? A day? Well, if there's no blood flow in that directly to that area, it's not going to be a day. So now how long? 2 days? 4 days? A week? Really, if you want to talk about a long-term program change, which is what I want you guys thinking of when you're working with someone, a long-term programmed, scaled change to collagen could take up to a year. That involves retraining whatever the movement is involved in that area, making sure that there's a proper blood flow to the area and return from the area, making sure that the neurological system is aware of the change. These are the things you should be thinking about. So it's not done. Treatment may happen, but the process of change can take up to almost a year, 10 months roughly. Right? What if it's elastin? What's the process for elastin to change? So we've talked about collagen. Think of elastin as having a similar process, right? Or how long does it take to reprogram the matrix? How long does it take for change at the level of the cells of the connective tissue. Now we're talking about a month, right? Fluids, almost instantaneous. 1 day, there's a change. Matrix, anywhere between 1 and 5 days. That's a time scale of change. That means the treatment you do on the matrix today has effects that, show up and change and reorganize for up to 4 or 5 days afterwards. What does that mean for us? Well, let's give you an example. You have an injury to we'll use ankle sprain again. You've got an ankle sprain. Oh, we all hate ankle sprains. I'm in so much pain. What do? I take a painkiller. Which one? Suggestions? Advil. Oh, the mighty Advil. One of the top 20 most valuable medications according to our God Google. All right. How's it get there? Sorry, when you take an Advil, it just works in the ankle? No. It's systemic. And does Advil really work on pain? Yeah? Yeah? No. So, it really is actually useful, Advil, because it's primarily anti-inflammatory, secondary pain relief. So it's actually a good choice for that ankle because it's working on inflammation. But what's the barrier? The barrier is blood flow. When you have an ankle sprain or any sprain, and there's tearing of a ligament, there's ecchymosis. What's that? That's like blood in the tissues underneath. You get bruising, which means what? It means no blood supply that area, right? That area has to be drained by a secondary system of lymph and larger veins because you've wiped out the small ones. That's what bruising represents. Those tiny little venules, poof, gone, right? They'll be reorganized, hopefully. And what's the big factor that comes in and helps out clean that debris? Lysozymes. Now you might say, oh, lysozymes, I'm not scared of them. They don't scare me. Well, what do lysozymes do when they're in that area? They're mowing down on tissue, removing tissue. And when do they stop? What's a signal to make a lysozyme stop in an area of the body? Which hormones? Anyone know? Trick question. There is no hormone. What deactivates a lysozyme? Nothing does. It's the liver that takes them and reprocesses them. How do they get to the liver? Blood flow, venous system, right? So immediately you should be thinking of already in your mind, right? Systemic issues. What's one of the most important tools to resolve systemic issues? The venous system. Why? It's bringing whatever junk is in an area back to be processed by the liver. That was really important for us. Okay, so I've kind of talked a little bit about ankle sprain. And I think it's worthwhile for us to consider that a little bit. This is more material from the first lecture. Okay, so here's a concept, and I'm going to highlight a few concepts. Not that you guys haven't heard these. You're hearing them ad nauseum, in our lectures. But for the sake of bringing this all home to make it more comprehensive, here's the concept I'd like you guys to consider. Heterogeneity versus homogeneity. What I mean by that, hetero, different, homo, the same. So, in our context, this is how we start to distinguish whether something is local, regional, or systemic. By the way, I'm going to give you guys this lecture if you want it. Okay. Class is free, but lecture's $1,000. Okay. Anyways. So, how are you going to distinguish heterogeneity versus homogeneity? Are you going to ask him? Her? Are you going to guess? You know what I like to do? I have one of these crystals, and I take it and I swing it, right? And I know that, like, if it goes more that way, it's heterogeneous, and if it goes more this way, it's homogeneous. That makes sense? No. So what are you going to use to decide if the process is heterogeneous or homogeneous? We're going to use our eyes. We're going to use our listening, our ears. We're going to use our hands. What does that mean? It means if you listen carefully and you look carefully, you can see patterns. So, for example, has anyone ever heard the term of malar flush? Malar flush refers to an autoimmune process in which you get this reddening, usually along the patterns of trigeminal vascular system. Malar meaning maxilla bones. Right? So you see someone with malar flush, but the skin color is the same everywhere, different everywhere else. It's more pale, it's more normal. What does that tell you? It tells you there's a local issue. Even though the sign is out here, it's not a maxilla problem. Well, it could be, but it's not likely to be a maxilla problem. It's a problem of a transverse structure, i.e. tentorium cerebelli. And the blood vessels and nerves are contained and controlled by it. In particular, all the foramen and cranial base. Right away in your head, you should be like, foramen cranial base, tentorium cerebelli, malar flush. It's a pattern. Now, that's just one example. What if you see something systemically in the skin? What should you be thinking? Well, if I have a pattern that's in my, for example, arm, leg, and along the sides of my body, most likely this is something that affects the whole system. Right? The whole system of skin is like the nervous system. These are tied in together. Embryologically, your skin is ectoderm. Your nervous system is neuroectoderm, ultimately from ectoderm. Did anyone see that recent article about the pain-sensing nerves in the skin? Pain-sensing organ in the skin, I think they refer to as some recent research, right? What they refer to, glial cells. Anyone ever heard of glial cells before? Where are they? In your brain. They're associated with nerves. Go figure. They're actually part of the protective system of your brain, like astrocytes. Doesn't it make sense that if brain and skin come from the same embryological tissue, they might have some similar cell types, like glial cells? 100%. Is it the same kind of concentration? No. I mean, there's a very dense population of glial cells in the brain, and it's much more sparse in the skin, but it's still there. Same principles, same operating system. Okay. So now with ankle sprain. First off, we look at our ankle. You guys remember all of your orthopedic testing, right? And you're thinking, say, of an inversion ankle sprain, right? So you're thinking of the ligaments that are involved. You're thinking of your tarsal sinus, right? These are all very local things, and they're all important to address. You've also, at this point, you guys know or should know all the containment fascias of the foot and the rest of the lower extremity. And if you don't, you will learn them this year, in the second year. Okay. Now, if this person has poor connective tissue systemically, right, which we're testing with our skin fold test, right, our pinching tests, right, and we're looking for changes, right, and everything looks about the same. You do your skin test, you say, this person's fluids, it's not so good. Connective tissue's not so good, right? What are the chances if the person has poor connective tissue systemically, the healing process is going to go well at the level of the ankle? Not very good.